Thank you so much for joining us, guys. I am Kimani Hendricks, Multimedia Communications Coordinator for MS Focus, the Multiple Sclerosis Foundation. And if you don't already know, you are watching a program presented by the organization. We are here today with Cherie Benz, who will be sharing information on the impact of hormones on MS across the lifespan. We will address your questions and comments after the presentation. But for now, I'll just get into introductions. So Cherie Benz is a registered nurse with a degree in gerontology, and she is also a certified MS nurse. She's a regular presenter and patient healthcare liaison for MS Focus, Multiple Sclerosis Foundation, and she also writes for our quarterly magazine. In 1994, Cherie was diagnosed with relapsing remitting MS, but she's found that she has adopted some challenges or she's adopted some changes, my bad, to her lifestyle that have made MS much easier to manage. So Cherie, thank you so much for joining us, and I'll turn it over to you.
Thank you, Kamani. The title of this webinar seems to indicate that hormones impact us as individuals, whether we're male or female, across the lifespan, and that's really not true. Although men actually do produce testosterone through their entire life, even though at the end of their teens, they tend to drop levels a little bit, but not to the point where it should be negatively impacting their quality of life. Some men do have low testosterone levels that have MS. We don't know why that is. And supplementing that testosterone has been found to improve the impact of some of the MS symptoms that they're experiencing. So I just want to throw that out right at the beginning. That said, we're really going to focus mostly on hormone changes in women because they're so much more impactful, as we now know, than any changes that might happen in men over the course of their lifetime as far as it impacts MS symptoms. So one of the things that I found to be very interesting as I was sort of doing some research to get ready for this webinar is that at the moment, 30% of all individuals living with MS are perimenopausal. That means that we are getting ready to start into menopause. And that's not just women with MS, it's 30% of the entire MS population. I thought that was awfully high, but if you figure that there are 3 to 4 women for every man that's diagnosed with MS, it kind of puts it into perspective. So perimenopause is a period of, on average, 7 to 10 years, where our hormones start to shift, start to decline before we hit menopause. Now, menopause technically is when you've been without any period at all for the span of at least 1 year. Once you've been that long without a period, you're considered to be in menopause. But there are a lot of symptoms which we now know are perimenopausal symptoms and send a lot of women searching for a diagnosis. Things like cardiac irregularities and palpitations and shortness of breath on exertion. Things like vertigo, crystals in the inner ear, dry mouth, dry eyes, and of course, dry vaginal tissues. The peak suicide rate for women is during that perimenopausal area, actually between about 45 and 52. So more women that end up committing suicide do so during that perimenopausal time of life. Androgen levels, which are male hormones, men produce estrogen, Women produce testosterone naturally. So your androgen levels or male hormone levels tend to increase as you start to become perimenopausal. And that can cause things like male pattern balding or let's see, chest or chin hairs, male pattern balding, chin hairs, and even a shift in the way you perceive that you smell. So your body odor or body scent may change along with those androgen levels being raised. Now, another thing that normally happens during that time of life is that our neurotransmitters go haywire. Not just people with MS, but people in the general populace. So just think if your neurotransmitters are going haywire, and you've got MS on top of it, how much more impactful that can be. Up until about 5 years ago, we were told that um, these symptoms that we were experiencing as women were actually psychiatric, that they were hysterical symptoms, that they were related to stress. And we now know it's a very real, very physical complex. One of the things that often happens is frozen shoulder or carpal tunnel. And those things actually responded very well to hormone replacement therapy, which we'll get into a little bit later in this discussion. The National MS Society last year published the results of some studies about MS and hormonal impact. Now, if you go to the National MS Society's website, perhaps Bhavya can tick that web link into the chat for people and just search for menopause and MS or MS and menopause. Just make sure you've got those two search criteria in your search engine. You'll come up with a number of articles on the National MS Society webpage. That webpage has, and part of this MS with study that they've looked at related to hormones, they made note of a statistic that seemed surprising to me, and it's related to pediatric MS. So girls are starting to be diagnosed, girls that will end up with MS are starting to be diagnosed as little as 2.8 years on average after they start their periods. So we know that a lot of us actually have a lot of MS symptoms long before we actually get an official MS diagnosis. So I think maybe after we finish this discussion, there's going to be light bulbs going off. There certainly were with me. I know I was in the cardiologist's office so many times prior to and even after my MS diagnosis because of palpitations and irregular heartbeat that they couldn't find any reason for. We now know if we supplement or stabilize those hormone levels, those symptoms just melt right away. Same with the frozen shoulder or the carpal tunnel. The hormone therapy does seem to help that. The same with the dry eyes, the dry vaginal mucosa, irritability, all of that sort of thing is managed quite well with hormone replacement therapy. I saw on Facebook the other day that an individual on our large private Facebook page said that she was recently diagnosed with MS and was starting Ocrevus, and her neurologist told her that she had to go off hormone replacement therapy because she had MS. That is absolutely not true. Do not let anyone tell you that there is a reason for you not to take care of that facet of your life and make sure that the hormones are regulated. there's just more and more and more information coming out all the time. Over the last 5 years, there have to have been about 6 or 7 research projects that have been written up that state that MS in women actually stabilizes with hormone replacement therapy. That's not in lieu of your disease modifying therapy, but it certainly can help your symptoms to be far more manageable and less in your face, so to speak. Progesterone is also the estrogen and progesterone are our two main hormones for women. And progesterone actually plays a huge role in regulating sleep. So if your progesterone levels are low and you're having trouble sleeping at night, that's something to have a discussion with your doctor about, perhaps supplementing that progesterone for you. See here. I had a couple of notes I wanted to touch on with you. Um, Probably one of the things that is a indication to a lot of women that they may be starting into that perimenopausal area, that 5, 7, 10 years prior to actually stopping their periods, is hot flashes. And hot flashes, I remember the first hot flash I had, I was sitting in the office at the end of a work day, and it was the middle of winter. So I had a sweater or a vest and a jacket on as I was charting for the day. And all of a sudden it felt like within an instant from my waist to the top of my head, I just flushed and got really, really hot. The nurse sitting across the desk from me looked at me and she says, "Oh my God, you're beet red." And I had to take my glasses off because they were all fogged up. That elevation in temperature can make all of your MS symptoms worse. The same as heat can make your fatigue, your cognition, your spasticity worse. All of those things can be made worse with the temperature shifts that come with perimenopause and menopause. So again, that's another reason to sort of get onto some hormone replacement therapy that might help you with that. I discovered a doctor. Her name is Mary Claire, and that's Claire with an E at the end. Haver, Haver. She is one of 2,300 board certified menopause specialists living in the United States and practicing here in the United States. One of the things that she said was in a webinar that I listened of hers, or in a podcast that I listened to of hers, was that every single day in the United States, 6,000 women are perimenopausal or menopausal. And I see Heather says, "I love Dr. Haver." She is amazing. If you if you search her name and armchair expert, there is a wonderful podcast. It's 2.5 hours long, but it's got breaks every 20 to 30 minutes. So you can bookmark that and just take it in small chunks. She really gives you a course on the norms of hormone shifts as we begin into that perimenopausal area. She said most women tend to start it around at the average age to start perimenopause is around 41 for Caucasian women and about 37 for women of African descent. And she said, "I really don't know why that's the case, except that diets that are higher in fat and lower in really high quality protein tend to put people into menopause a little bit earlier. And since so much of, like historically in the southern part of the United States, where we have more persons of color than in the northern part of the United States, the diet tends to be a little higher in fat. and little, perhaps lower quality proteins, only because the economic situation often keeps people from getting that higher quality food. So just keep that in mind. The higher quality proteins, the lower fat diet may help to minimize some of the symptoms that you're experiencing. So let me see if we've got that Mary Claire in there. Bhavia, if you could put the link into the chat on the
Sure.
that I sent to you via email about Mary Claire Haver and the armchair expert. That link that Bhavia is going to put in is to that podcast I was just telling you about. And I've still got it bookmarked. I could go back and learn more every time I sit and listen to it because she's so comprehensive in what she's doing. She said that there are 55 million women in the United States right now out of a US total population of about 350 million. 55 million of us are perimenopausal at this point. Cognitive decline is one of the most common symptoms of those hormones backing off. So we often think that the cognitive decline that we're experiencing, the word retrieval issues, forgetting what you went into another room for, those sorts of things, we're thinking maybe they're MS related. And they tend to often not be so much MS related, even though about 80% of people with MS do have some cognitive deficit. So it's just potentially making that cognition worse. The other thing is that vitamin D supplementation we had thought would be helping this shift of hormones and helping the MS symptoms. All of the studies that have been done on that and looked at over the last 5 years have not borne that correlation out. There does not appear to be any difference between people that are not supplementing vitamin D and people that are supplementing vitamin D that are living with MS in the disease process. So, so there was a question in the chat as to whether or not the link for Mary Claire Haver is going to be shared in the YouTube channel. It won't be. It's only going to be on this Zoom. But any of you listening to the YouTube recording of this in another couple of weeks when it goes online, just search Mary Claire Haver, Haver, armchair expert, and that will bring up that hour or 2.5 hour webinar or podcast on YouTube. So you'll be able to have that. And again, if you want that link sent to you, respond to your registration email and we'll send it to you via email as well. I was asked if there are any women that maybe hormone replacement therapy are not, should not be on. And I would say generally no. If, however, you have a very, very strong history of reproductive cancers, breast cancers, ovarian cancers, and there's a strong family history of it, and maybe you even carry the genes for it, that's a conversation you're going to want to have with your gynecologist and probably your primary care doctor. I would say the gynecologist is more likely the person to answer those questions than your primary care doctor, though. And if you are gene positive for that, even if you've not been diagnosed with it yet, I would steer clear of requesting that hormone therapy until you've really had that conversation with with your gynecologist on that. Let's see. Hormone testing can be done, but one of the problems with testing your hormones is that our hormones wax and wane with our monthly cycle. So we're high in estrogen, and then as we move towards the time of ovulation, the estrogen drops and our follicle stimulating hormone increases. That's to make the egg sac develop and explode out of the ovary so that it can travel down the fallopian tubes and into the uterus and be fertilized. Once that egg has been released, the follicle stimulating hormone decreases and goes back to the baseline for estrogen. Progesterone tends to be more level throughout, but it does get lower as the follicle stimulating hormone rises. So some people have found that there are certain foods that actually mimic progesterone supplementation. Foods high in soy can give you a little bit of a boost that's almost a natural estrogen or progesterone production, not estrogen, I'm sorry. So things like tofu or soy milk or soy desserts, like a frozen soy ice cream, fake ice cream. Um, those sorts of things can sort of supplement that progesterone or mimic the supplementation of progesterone for you. Um, I have heard in some men that if they, particularly men that are vegan and are getting a lot of their protein from soy, it tends to feminize them. So they have a thinning of facial hair, maybe a raising of their voice. This is not common, but it has been seen in a few men. So if you're on soy yourself and you've got young boys or even adolescent boys in your household, just I would caution that they can have them, just don't rely on them for their major source of protein. I think what I would like to do, since I see a couple of questions in the Q&A and I did see in the chat that there were maybe some questions from Facebook community. Let's just throw this open to questions and we can go from there.
Awesome. So I'm going to start with the first in Q&A. I kind of like to go by the time they actually came through just to make it fair. So we have an anonymous attendee who asks, what about HRT and its relationship to breast cancer? This person has had breast cancer once and says, what are your thoughts?
I think we just covered that. So HRT is hormone replacement therapy. So when you hear anybody talk about HRT, or we don't say the whole word out, we're alphabet souping it. That's what it is. So again, if you've had breast cancer, if you have a strong family history of breast cancer, if you have genes for breast cancer, this is a conversation you need to be having with your gynecologist, because there are different types of breast cancers that may be more sensitive to hormone replacement therapy. It's something that's going to have to be tailored to you with that history.
The other anonymous attendee says that they were diagnosed with both MS and a large brain tumor 2 years ago, had brain surgery. They are now 50 years old and are being seen at a women's clinic, but never mentioned hormone therapy because they were told that their hormones were okay after blood work. However, they said they suffer from everything that you've talked about so far. So they said, could someone like myself still be okay to take hormone therapy? Any links with cancers, tumors, etc.?
All right, there was a study done. Oh gosh, Dr. Haver mentioned this. There was a study done probably 25, 35 years ago, back in the late 70s, early 80s, maybe. And the study indicated that women that were on hormone replacement therapies were actually doing better than those that were not. and there didn't seem to be any reportable increases in cancers in women that were on hormone replacement therapy. This had been a peer-reviewed article, and two researchers, both of whom were men, went through it and took out certain pieces of information and said that women should not be on hormone replacement therapy unless their swings were so drastic as to severely impact their lifestyle. And they also said that there's a great increase in cancer risk. And so for a long time, um, we were not utilizing hormone replacement therapy. Back in the late 60s, early 70s, it was utilized more than it was in the 80s and 90s because of these two men who looked at the studies and decided to edit them and comment on them on their own. We now know that what they published was absolutely not accurate at all. Women can do very well starting on hormone replacement therapy in their late 30s, early 40s, and continuing it up until their mid 60s. We don't like to keep you on much past 60 or 65 years of age because your body would naturally be menopausal by that point in time. Almost all of us are fully through menopause by the age of about 57, 55 to 57. Oddly, that is the time that we as women tend to meet our male counterparts in the degree and the rapidity of progression of our MS symptoms. And that's thought to be because the hormones are waning. So we're seeing women who are going onto hormone therapy progressing much more slowly than the counterparts who are not on hormone replacement therapy or HRT.
We have a question from Tanisha, who's watching from Facebook. I hope you can help her with this. It says, why is the age change with the culture of menopause? You know what
I
that
don't understand that question, Tanisha. Why does the age change with the culture of menopause?
I don't think.
Um, Maybe could you try rewording that question so we can help you with that?
Someone, Brandy asks to clarify, are you saying no benefits related, MS related were found in vitamin D supplementation?
That was they did actually, they talked to us a couple of years ago at the consortium of MS centers annual meeting about doing a retrospective overview of all of the clinical trials over the last 30 years on vitamin D supplementation in MS. We had every reason from everything that we know about the way vitamin D works and about myelin and its integrity and MS that vitamin D should protect myelin from being damaged. It should protect our nerve fibers and keep them intact. It should therefore slow progression of MS as we're taking it. And the thinking up until 3 years ago was that we needed to keep our vitamin D levels in the upper range of normal. So normal's like 30 to 100, and we were recommending that people keep their levels of vitamin D above 65 or 70. In that 65 to 75 range we thought was optimal. And what they told us 3 years ago was that not only does it not appear to be optimal, but it doesn't appear to have any impact at all on MS progression. And it doesn't have any impact on our MRIs or anything like that. So, what they're recommending, since vitamin D can be toxic if it's overdosed because it is one of the fat soluble vitamins and stays in our fat cells, unlike the B vitamins or C, for example, which if we get too much, we just pee it out. This is processed in our liver, it's stored in our fat, and it can become very toxic. And vitamin D toxicity, meaning that you've got too much vitamin D in your system, shows itself as either a severe gastroenteritis, like a stomach bug, nausea, not being able to keep food down over long periods of time, or chronic diarrhea, things like that. If you're having those symptoms, you probably need to get your vitamin D levels checked and ramp down the dosing. The recommendation that came out of the consortium when they presented these study results was that we aim to keep vitamin D levels now in people with MS between 35 and 50. It doesn't need to be higher than 50 anymore.
Kelly asked a question. I think you did touch on this a little bit, but if you had something to add, Cherie, it's fine. She says, do the symptoms associated with perimenopause continue once in full menopause, or do they typically subside or decline?
They generally disappear altogether. So it's the hormone shifts and your body trying to get used to those shifts that causes those symptoms in menopause. And they tend to make our MS symptoms worse. Just like if you've got a cold, you're not feeling up to par, your menopause, or not menopause, your MS symptoms are going to come across as being worse to you. You're going to feel less well. In the same way, when there's anything going on in your body that's a change, you may feel less well until your body adjusts to it. And unfortunately, because those symptoms the hormones are all over the place during that perimenopausal several years, you don't have the chance for them to taper off, level off, and adjust. But once the hormones have actually tapered off completely, the impact on your MS symptoms has been really damped down. So it's not going to be real difficult, and the symptoms of your perimenopause are gone. So they're not going to linger once you're fully through menopause.
Nicole from Facebook asks, has there been any research on women with naturally higher testosterone? Like, I'm assuming PCOS, she means polycystic ovary syndrome, and how that may impact MS progression.
It actually, in some cases, I think women are seeing those with polycystic ovaries that have MS are seeing more severe MS symptoms. Perhaps not all of them, but it has been reported that they're seeing more severe MS symptoms. Oddly, though, a lot of us experience a decreased libido, particularly as we're going through that perimenopause time. And one of the best ways to treat that low libido level is to give you some testosterone supplementation. It tends to improve the libido in most women. So, yes, the high levels of testosterone have the potential to make your MS symptoms worse, but generally, we can safely supplement with testosterone if need be.
Stacy asks, is HRT contraindicated for women on Ocrevus?
It is not. It is not contraindicated for any of our 24 plus disease modifying therapies. You can take hormone replacement therapy or HRT with any of our disease modifying therapies.
Karen says at 66, I've never been on HRT, diagnosed with MS at 61. I've heard that starting HRT at my age is not advised, even though I have no cancer or heart risks. Would you suggest that I try to see the GYN to inquire about HRT?
No. The only reason women our age, women over the age of 65, would need any hormone supplementation is perhaps with an estrogen vaginal cream if we're having repeat urinary tract infections. the repeat urinary tract infections in women in that age range over the age of 65 are often because of very, very dry vaginal mucosa. And what it does is the natural antibacterial lining of the vagina has deteriorated. And so it's growing bacteria, which is so close to the urethra that it's getting up into the urethra and into our bladders. Women have a very short urethra. It's about 3 inches long or less in most women, whereas men have a urethra that's 3 times that length. So the bacteria in men is often peed out before it ever gets up to the bladder, but with women, it makes its way into the bladder. So an estrogen cream for vaginal use might be given to a woman over the age of 65, but generally, no, you don't need hormone replacement therapy after that age.
Women go through so much. It's like, give us a break, even if even a little bit. Maria from Facebook asks, have I missed the window of benefiting from HRT if I'm 54 and last had a period 5 years ago?
You may well have missed that window. That's not to say that if you talk to your gynecologist about it, that they may, again, try you with something like a vaginal cream. Um, and that in itself could put enough of the estrogen back into your system that you may notice skin wrinkling, for example, is minimized. In fact, Dr. Haver mentioned in the podcast that you have the link for that many women are actually using a special formulation of a facial moisturizer that's got a little estrogen cream added to it, and that seems to help minimize wrinkling in women that are in their 50s, 40s, and 50s.
Amy asks, can you clarify why perimenopause is bad or worse for people with MS?
Again, any comorbidity, anything that's going on in the body that shifts the way you're feeling or the quality of life tends to impact your MS symptoms and make them worse. If you've got an infection, if you've got a UTI, if you've got a cold, if you've got COVID, if you've got an infected cut, if you've just had dental work, if you've had surgery, your MS might feel like it's getting worse for a short period of time until healing has taken place with whatever's gone on. So the hormone replacement therapy or the changing in hormones can actually make your MS symptoms feel worse.
I have a question from Lourdes. She says, can HRT and MS medications be taken at the same time?
They absolutely can.
And Tanisha from Facebook again, she asks if the diagnosis age is technically 2.5 years after a period, do I need to get my daughters tested for MS?
No, no, and we wouldn't do any testing for MS unless there were symptoms.
Hmm.
So there's about 256 genes that we have identified that seem to be activated in people living with MS, but that doesn't necessarily tell us that our children have a higher risk of developing MS if they have those genes.
Amy wants to know where she can read the studies about women on HRT decline slower than women are not.
The National MS Society website.
I think Bhavia posted the link
Yeah, the
earlier.
link is in the chat.
Awesome. So I'm going to jump back to Q&A because I know we have had some questions in there. Jennifer says, you may have talked about this already. I was late to join, but what's the relationship with changes in estrogen and TSH, can a woman in perimenopausal state, can she still get her period and take HRT?
She can still get her period and take HRT. There's not a huge relationship that I'm aware of between estrogen levels and TSH, which is the thyroid stimulating hormone. So, but that being said, Hashimoto's disease is an autoimmune hypothyroidism. And so many of us who are living with MS have Hashimoto's disease, which will skew your TSH levels or your thyroid stimulating hormone levels.
Harry says, I recently got an IUD for progesterone along with the estroidal patch. I don't know if I'm saying that right. You can jump in and correct me if I am wrong. She says she definitely feels better. Do you have a recommendation for one for the progesterone?
Um, so is your some IUDs are actually coated with hormones. So I don't it kind of the question made it sound like her IUD was progesterone treated.
She says here she chose the IUD as it does not pass through the liver and she's on Ocrevus. So they thought this would alleviate liver overtaxing.
Um, I don't think most people on Ocrevus can be on Ocrevus for a decade or longer and never have it impact their liver. It is one of our disease modifying therapies that is on lower down the list as far as impact to the liver. Our female hormones don't generally impact the liver negatively. So the estriadiol patch that you mentioned. Um, is one of the standard, HRT therapies that's used. There are patches that have both estrogen and progesterone in them, and they're absorbed time release absorbed through the skin. As you wear the patch. Just make sure if you're using the patches that you put the patch on a different place every single time. Um, you know, on your back, on your upper arm, on your tummy, places like that so that you're not, you're exposing different areas of your skin to absorb that.
Summer asks if one can start HRT too early.
Um, I don't know about too early. You probably wouldn't be prescribed HRT if you weren't symptomatic of having some of these perimenopausal symptoms, the vasomotor symptoms, such as the hot flashes, the cognitive changes, the dry eyes, mouth, and mucosa. All of those things are going to be there before you start an HRT. So generally, most women don't start HRT until their 40s. But if you're a woman of African descent and you're starting to have these symptoms, and particularly the dryness and the vasomotor symptoms with the hot flashes, I would think they would want to start you in your 30s if that's when it's happening. So as far as starting too early, you treat the symptoms. So if you don't have the symptoms, you're not going to be on HRT.
Katie says, I've read about studies using metformin for lowering systemic inflammation. Is it possible the vitamin D is beneficial, but should we be also focusing on lowering overall inflammation to get the most out of vitamin D as well as helping with insulin resistance and perimenopause?
Again, these are things that have been talked about over the years as benefits of vitamin D. None of that was shown to be helpful in their studies looking at all of the clinical trials that looked at vitamin D. So all of those questions were answered negatively in that study overview.
An anonymous attendee asks, can the hot flashes act like a pseudo exacerbation?
They certainly can. Um, I know that um, when I'm outside during the summer and I get overheated and I come inside to an air conditioned room, put on a cooling vest and collar, my symptoms subside within half an hour. With a hot flash, those symptoms can actually stay for hours and hours and hours. Um, and you can't seem to cool down. I do find that when I was actually going through this, I didn't have a cooling vest. Cooling vests are my lifeblood for the summer now, but I never really, I could cool. I could put ice packs on my neck and it would help, but with a hot flash, they don't go down like they do with a standard MS overheating.
Jennifer wants to know what's considered a high level of testosterone.
I don't know. Your doctor would have to know that. When you have the testosterone levels checked, again, there's a numerical value with a low and a high normal. So I don't know what those levels are, but your lab value would tell you.
I'm guessing Wendy, I'm not sure if she was late in coming in, but I believe that Cherie did touch upon, when one is fully through menopause and whether or not hormones continue fluctuating beyond the 1 year mark of no period.
Yeah, the hormones don't fluctuate as much as they continue to taper off. After, again, menopause is officially declared when you have had no menstrual activity at all for a period of at least a year. And the hormones do continue to taper after that period of time, but the fluctuating symptoms don't. And so once you're fully menopausal, within 5 years or so after you're fully menopausal, we like to get you off that hormone replacement therapy and they taper it. So you don't have you don't really go into a false menopause again or a perimenopause.
Jennifer says she joined late, but she would like to know, if possible, uh, to ask for a hormone panel through her PCP or MS neurologist.
Nope, nope, not appropriate. Only because our hormones are constantly changing until after we're through menopause. So you have to know exactly where you are in your cycle to know whether your hormone levels are normal or not. If you're one of those persons like I was, where you're like clockwork every 28 or 29 days with your cycle, then you know that 2 weeks after your period, you're going to be ovulating, and 2 weeks after you ovulate, you're going to have your period again. If you tell your doctor and they're drawing a hormone level just to check, they're probably going to want to draw them at both the period level and at the ovulation level to make sure that your levels are treating you normally. But normally we don't check hormone levels because in most women until after the age of about 55, our hormone levels are all over the place.
Rhonda says that she's getting some pushback from her doctor because she wanted to get estriol for HRT and for MS, and she wants to know how she can advocate for herself to get that instead of estradiol.
Estriadol,
Estriol.
it would depend on how old she is. You know, I would say if she is truly perimenopausal, she could get it. It is not approved to treat MS. So no, we have been doing studies because we know that estriadol, when it's the one time in our lives where estriadol is naturally produced in women is during the third trimester of pregnancy. And during that third trimester of pregnancy, most women feel better as far as their MS is concerned than at any other time in the course of their MS. And so we've done studies on estriadol to see if that helps the MS symptoms or slows the MS progression. And we really haven't seen that so far. So if you are menopausal or perimenopausal, that's appropriate to request estriadol, not for treatment of your MS.
Anne Marie says she's 16 and 62 and past perimenopausal stage. She says that she has experienced all the symptoms you've mentioned so far, and she still needs HRT because she has lichen sclerosis and skin splitting with serious atrophy internally and externally. And she wants to know, is there any problem taking HRT in her state?
Well, she's got a specific condition for which HRT is also used, not just perimenopause, but the lichen sclerosis. And that's a skin condition which can be either on the skin itself, any place on the body, or in the vaginal mucosa. And that does need to be treated. So you need to rely on your doctor in that instance for it. And again, we don't generally take women off of HRT until after the age of 65, and she's well within that age range to take it.
Kendra says that she's 54 and has just started to have irregular periods and wants to know if she should start to seek treatment through HRT.
I would, I would certainly, if you've got a gynecologist, that would be my first choice of where to go for this. But again, most gynecologists don't know as much as a board certified menopause therapist like Dr. Haver is. And for those of you who joined late, way back near the beginning of the chat is a link for Dr. Mary Claire Haver, Armchair Expert. There's a 2.5 hour long podcast that's broken into 20 to 30 minute segments. And it is a wonderful, wonderful, wonderful resource to talk to you about the various changes in our bodies with hormone shifts over the decades.
Desiree from Facebook asks, she says, I deal with heat incontinence. Should I be concerned with the intensity of hot flashes when I hit menopause?
Absolutely. So you would be a prime candidate for hormone replacement therapy once you start experiencing some of these shifts. And again, as I said a few minutes ago, I found that my heat intolerance, which is pretty severe with my MS, was way worse with a hot flash. And the hot flashes don't respond to cooling as well as your MS overheating does.
Randy has another question. She says, did you just say, like 10 minutes ago, did you just say someone likely can't be on Ocrevus longer than 10 years without it affecting their liver?
No, 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 no. I said people can be on Ocrevus for 10 years or more without it ever affecting their liver. So just the opposite of that. Ocrevus is not a drug that tends to impact the liver, like many of the other drugs that we have. So you can be on Ocrevus for years and not have any liver problems as a result of that.
Nicholas from Facebook asks, if pregnancy reduces MS disease activity, has there ever been any study trying to replicate the hormonal conditions of gestation in someone with MS?
Um, Again, the estriadol trials, yes, but estriadol trials, it's unethical for us to um, do those trials on anyone other than people that are genetically female because that hormone is only ever produced in somebody who's genetically female in their third trimester of pregnancy. So, and it has not seemed in the clinical trials that it has that much of an impact on MS in general in people that are not pregnant.
Amanda Says, any thoughts on LDN for MS symptoms? I'm also on DHRT.
Uh, BHRT,
I don't know.
I
That's
don't
I'm
be, I
reading
don't
it.
know either. But LDN, low dose naltrexone, can help minimize some of the MS symptoms that people are experiencing. Generally, we find that to be the case in older individuals over the age of 45 or 50. Those may be individuals who are what we have been referring to as secondary progressive MS. It's an older, more mature form of MS that isn't quite as active as a relapsing form of MS. It does boost mood, and I think that that's one of the reasons that symptoms are perceived to be less severe when somebody's on LDN. So it's a drug that does not impact your MS per se in any way, but it does impact your perception of the severity of the MS symptoms. And for that reason, many people feel better taking it.
Mary Lee says she's finding it so difficult to differentiate what her MS symptoms are and her perimenopausal symptoms are. She says that she's going through brain fog, sleep issues, and she says that she started in HRT and is finding that now her balance and dizziness have increased and wants to know if you think this is normal.
Not really, no. I would wonder when the last MRI was, and if there's any new disease activity showing up on the MRI. Also, doesn't say whether she's on a disease modifying therapy. And, if you're not on a disease modifying therapy, it's probably a combination of untreated MS and the hormone shifts, and that could be a pretty nasty combination.
Jane wants to know what is Hashimoto and why should people with MS have it more often? No.
Hashimoto's disease is an autoimmune hypothyroidism. So if we've got one autoimmune disease like MS, it's highly likely that we can have more than one, such as lupus or rheumatoid arthritis or Sjogren's or Hashimoto's. You just have a higher probability if you've got one to have more than one. It's not that MS causes Hashimoto's disease. It's just that many people with MS do have Hashimoto's disease or are hypothyroid. The way to determine if it's an autoimmune thyroid problem or Hashimoto's is by doing thyroid antibody testing. A regular thyroid test does not show that it's Hashimoto's. You have to have thyroid antibody testing to determine that. It is still treated the same way that regular hypothyroidism is treated.
Chris O'Brien has it's fairly simple question. I think they want to know where they can get a cooling vest. I know that the Multiple Sclerosis Foundation has a cooling program that's actually about to start where you can apply at msfocus.org. But I'm not sure whether or not if you put your application through now, if it will come in time for the summer. So maybe you can refer someone else, Cherie, if you know anybody.
Our cooling program at the foundation runs from February 1st to June 1st every year, so it's just ending. And when I was in the office in Fort Lauderdale last week, I heard that we've got more applications at this point than what we can fill. So you can apply also for cooling vests to the Multiple Sclerosis Association of America. And if Bavia can find the web address to that and pop it into the chat, go ahead and do that. If you're able to purchase them, there are several companies. You can just Google cooling vests and you'll come up with half a dozen different companies that sell cooling vests. I know that You can get them on Amazon. A wonderful small family-owned business in Ohio called Polar Products is one of the providers of cooling equipment for our cooling program, and they really work so well with the MS community, and they know what our needs are. And if you able to purchase them, go to polarproducts.com. They do have a wide range of really good products, and they're the ones that I actually wear the most, that seem to keep me cool the longest.
We have a question from Tanya. She says, what if someone has large ovarian cysts and aden adenomyosis, and
Adenomyosis.
she
Yep.
can still take HRT?
Again, that's a question for your gynecologist. It's a very specific um, problem that's going on that needs to be addressed before you start adding things that somebody who has no other problems is dealing with. And it's something that probably will be impacted because it's related to ovarian function. So your gynecologist is really the only person that can answer that question for you.
Cherie, we are actually just reached the top of the hour. It goes by so fast, and you answered so many questions already. We still have a few left. I don't know if you have about 5 minutes to take one more question, or if you would just prefer to save the rest for the next time you're with us.
We can stop by 10 after 4 if you want to.
Sure.
The other thing is that if I wasn't clear with something, or we don't get to your questions, you're welcome to email me at Cherie at MS Focus, and I will get back to you with an answer to specific questions.
And that's Cherie at msfocus.org. Um, so Nicole says, Dr. Haver has said that a hysterectomy can lower your age of onset by 4 years. And I experienced that and started an HRT at 39, even though I kept my ovaries. She says they were damaged by endo. Can I expect to need more estrogen replacement later as I age, or will the dose stay the same?
I suspect it'll stay the same. I I had the same sort of thing. I had a hysterectomy at 42, and I did lose part of one ovary, but my levels, I'm sure, were low, and they just were not dealt with at all for the entire time of my perimenopause. I was told that it was emotional and sent to psychotherapists. So again, this is something only in the last 5 years or so we're beginning to see really being taken seriously. I think you can probably very safely continue on that HRT for as long as you need, but probably not past the age of 60 or 65.
It looks like as of right now, we have one more question in the Q&A from Trisha. So finished right on time, just about. She says that she stopped taking beta seron in August 2024 after 31 years because of the injection site issues. And they have not been on medication, still looking for meds that are just as good for her, but not any injection, and wanted to know if you had ideas.
Um, I don't know how old you are, Tricia, but if you've
She's
been on
56. She did say that.
56, okay. Um, A lot of that depends on whether or not you've had a relapse during the last 5 years or any new disease activity on your MRI. We have more than 24 medications right now, and actually beta seron is one of the very least effective medications on the market. So there are many medications out there in pill form or in infusion form where you go in for an infusion once a month or once every 6 months, that are excellent. But if you'd like to email me, we can have a discussion via email about that. Try to find something that you're comfortable with.
Well, that brings us to the end, everybody. Thank you so much for joining us. There were well over 100 people in the room alone on Zoom, so that's good numbers. And everybody saying thank you, thank you, thank you, thank you, thank you. So, and I can mirror that and just piggyback off everyone. Cherie, thank you so much for taking the time just to answer these questions and to stay a little bit over. We always appreciate having you. It's a joy to watch you navigate these conferences. I don't know how you do it without taking a sip of water, but you do. And we're so glad to have you. Everybody, our next conference will be next Tuesday with Dr. Ben Thrower, and he will be doing his town hall series, Ask the MS Expert. So you can bring all MS related questions to him. And just like Cherie sat with us for an hour and just rapid fire answered questions, he will do the exact same thing. We actually do have a survey that you guys, we would hope you can take it for us just to let us know whether or not you enjoy the conference and any other feedback, things you would like to see for future webinars. We greatly appreciate it. And for those of you who did come in late, you can visit Multiple Sclerosis Foundation's Facebook page, and the live stream will actually be visible, and you'll be able to watch it from the beginning once we close out on Zoom here. In about 2 weeks, it will also be on the Multiple Sclerosis Foundation's YouTube channel. And yeah, that's pretty much it. We hope you guys enjoyed. We thank you so much for being with us this afternoon, and we hope you have a great balance of your day. Take care. Be safe, everyone.